Hello and welcome to BunMed, where we discuss concise medical knowledge that you can fit inside of a bun. So today we'll be looking at the anemias, specifically just about the mechanisms at which they come about, and also how we can go on to classify them based on that. So first of all, let's just break down the word. What does anemia actually refer to? Well, an refers to a lack of, and emia refers to the blood. Thus, in anemia, we have a lack of not exactly the blood, but what makes up the blood, specifically what makes the blood red, hemoglobin, or indeed the things that carry hemoglobin, the red blood cells. Now, before we get into how we have a lack of red blood cells, let's find out where red blood cells actually come from. So we know they come from our bone marrow. And inside of our bone marrow, we have these cells known as the hematopoietic cells, the stem cells essentially that go on to form all of the cells in our blood. But who tells the hematopoietic stem cells that you have to become a red cell? Well, it turns out the process starts at the kidneys with the production of a hormone known as erythropoietin. Erythropoietin, or EPO for short, is released into our circulation. When it reaches the bone marrow, it signals our hematopoietic stem cell to go down the myeloid lineage and become a myeloid cells. And after a lot of changes and a lot of intermediaries, eventually our cell goes on to form the beautiful biconcave shaped erythrocyte that we know and love. Now, this erythrocyte has a shelf life. It exists in our circulation for around about 120 days, where it's nice and plump. However, over this time, as it ages, it starts to develop defects, and we therefore need a way to recycle them. And this is done by our spleen, which detects old red blood cells and after 120 days starts to actually break them down. Hemoglobin, thus, is broken down into its breakdown product known as bilirubin. Now, we needed a way to get rid of bilirubin from our body, and this is done by our liver, which takes the bilirubin and conjugates it so that we can get rid of it in our feces. Now that we have an understanding of what anemia is and how the red cells come to be, we have to understand one very basic concept. And that concept is that anemia itself is not a diagnosis. We can't just tell a patient you've got anemia and that's the end of it. We have to go on to find the cause of anemia because without that, a diagnosis of anemia is not very useful. And to go to the root cause of an anemia and to classify it, we have to understand this idea of a mean corpuscular volume. So what does that mean? Well, we know the use of the word means there's something to do with averages. So mean corpuscular volume refers to the average volume of our circulating erythrocytes. Okay? And we can break this down into three types. We can have a low MCV, and since we have a low volume, we're going to have smaller cells, these cells known as microcytes. Micro meaning small, cytes meaning cells. So we have a microcytic anemia where we have lots of small red cells in our blood. We may have a completely normal volume, and therefore we get a normal MCV. Therefore, we're going to get normocytic anemia. Normo meaning normal, cytic meaning cyte. So we have a normal volume in our circulating red cells. And lastly, we could have a high MCV, and this is something that we'll know as a macrocytic anemia. Macro referring to large, and cytic again referring to the side. So you can see how just by understanding the first word, we can actually work out what type of cells that we have. So now let's use an example. Here we have some blood. So pause the video and just have a go at interpreting this. Okay, so we can actually see that we have a low hemoglobin. So we know this is an anemia, as our lowest should be 135. We can also see that we have a low MCV, as our lowest boundary should be 82. So we can quite easily go, this is a microcytic anemia. So we've already classified the type of anemia this is. But again, we haven't got to the root cause of this anemia, and we can't without doing any more investigations. So what might be the mechanisms that lead to this anemia? Well, that's what we're going to come on to in the next coming minutes. But I want you to understand a very few concepts before we go on, and that's, do we have an issue with the number of total cells being produced? Or do we have an issue with what's actually making up the cell, the composition of the cell. For instance, you have an issue with the composition of the hemoglobin. Because if we have an issue with the total number of cells being produced, we're always going to have a normal MCV. Whereas if we have an issue with the composition of the cell, say for instance we have missing ingredients or something, then we're going to have a varied MCV. And this will all become clear in my next slide. Right, so now that we have an understanding of what we're looking for in our anemias, and that's to do with our volumes and what type of cells we have, let's have a look at this diagram again and see where in the process it might go wrong. So where can we actually go wrong? Well, erythropoietin is the thing that kickstarts the whole process. So if we have some issue with erythropoietin production, say for instance where erythropoietin is made in the kidneys, so if you get chronic kidney disease, we are going to end up making less erythropoietin. And therefore, since we're making less erythropoietin, we're going to be making less blood cells because we have less hematopoiesis going on. Now look, we've turned off erythropoietin. Therefore, we've simply reduced the total number of cells we're making. We haven't changed the constitution of the cells or what makes up the cells. So, applying our formula from last time, we can see that we're going to have a normal MCV. So let's move on to where else we could go wrong. Well, our hematopoietic stem cell or the bone marrow might go wrong. What might happen? Well, let's think about some structural changes that might occur in the bone marrow, something like myelofibrosis. Myelo refers to the bone marrow and fibrosis refers to the scarring of. So if we get scarring of the bone marrow matrix, we get fewer hematopoietic stem cells, and therefore we get less hematopoiesis all over again, okay? What else may happen in inside of our bone marrow? Well, we might get a cancer of the cells, something like leukemia, or what's a pre-leukemic condition? Something like myelodysplasia. In either case, we have infiltration of the bone marrow and occupation of that space. Therefore, we again get less hematopoiesis going on. And therefore, again, we're going to have less red cells. What else may happen? Well, we might get something like myeloma, where we have an excessive of plasma cells. So therefore, again, we have an infiltrative cancer. Therefore, we again have less hematopoiesis. And lastly, we may have an infection of the bone marrow, something like parvovirus B19, which may mean that we get an aplastic anemia, which means that again, we get less hematopoiesis. Again, we're not changing what makes up our red cells. So applying our formula, we're going to see a normal MCV. Okay. Now, where else could it go wrong in the process? Well, if we now start to alter what makes up the red blood cells, say for instance something like iron, which is needed to make hemoglobin, this is when we start to run into troubles with our MCV. So if we have less iron, iron is required to make hemoglobin, right? So if we have less iron, we're going to have less hemoglobin. And because we're changing the makeup of the cell, applying our formula from earlier, we're going to have a low MCV. You can see how the MCV has now changed. So we see a microcytic anemia. Iron deficiency is one of the most classical causes of a microcytic anemia. What if we have a B12 or a folate deficiency? Well, again, we are now changing the makeup of the cells because B12 and folate is needed by red cell precursors to be able to go on and divide and make lots of red cells. So because we're changing the makeup of the cells, we get changes to the MCV. And in this case, we have a high MCV, a macrocytic anemia. Okay, now let's move on. What if the cells we're churning out, they're okay cells, but they have some defects on their membrane or inside of the hemoglobin that they're producing, okay? Who's gonna pick that up? Well, our quality inspector inside of our body is our spleen, right? Its entire job is to monitor the circulating cells and remove any faulty ones. So when we have a cell like the one shown now, where we have a sickled cell, our spleen is going to detect that. And it's going to remove this cell in a process known as hemolysis. Hemo referring to the breakdown of, and lysis referring to the splitting of. So if, say, for instance, we had an issue with the membrane, a membranopathy, which means essentially a pathology of the membrane, or say for instance, an enzymopathy, an issue with the enzymes inside of our red cells, something very classic like G6PD. Or indeed, we have some hemoglobulinopathy, where we have an issue with the actual hemoglobin formed, something, say, for instance, like sickle cell disease. All of these changes are going to get detected by our spleen. And our spleen is going to start removing all of the cells that are faulty from our blood. Now, in this case, we haven't messed with the makeup of the cell. There's some genetic side effect there, but in reality, the biggest pathology is that we're getting more breakdown of our cells. Okay, so what does that mean for our MCV? Well, we're going to see a normal MCV in most cases. Now, our body tries to compensate for this in a process known as a reticulocytosis. Essentially, what this means is our body produces lots and lots of red cell precursors to try to compensate for the fact that we have lost quite a lot of our blood cells. Okay, let's move back over to the ingredient side and what makes up the red cell. We said that an iron gave you a low MCV and B12 gave you a high MCV. What if you had a deficiency of the both? Well, then the two cross each other out and you end up getting a normocytic anemia, which is very strange and quite interesting. And lastly, what if we have an issue with transporting the iron around the body? What if we have an issue with mobilizing our iron stores? Well, this is the case in chronic disease. And therefore, we tend to see an anemia of chronic disease, which can be either normocytic or microcytic. Finally, to just wrap up the video, imagine you're now in a ward round. We're not always going to have time to draw out a lovely picture like that we did before, so we just need a quick fire way to just fire off some anemias in each group, especially if your consultant just asks you, name me 2 or 3 different types of microcytic anemia. And for that reason, I like to use a few acronyms. So these are acronyms either my GP tutor has taught me or my friends has taught me. So that's what we'll do. So firstly, let's just break it down into the 3 columns that we have. So microcytic, normocytic, and macrocytic. And for the microcytic section, props to my friend who came up with this. I use the acronym TICCLE, so TICLS, T for beta thalassemia, I for iron deficiency anemia, C for anemia of chronic disease, so chronic disease, L for lead poisoning, so this is very, very rare. And again, S for something again very rare, something called sideroblastic anemia. Okay, in terms of if we had to reel off a few things for normocytic, well, we know it's going to be anything where we have infiltration of the bone marrow, so infiltrative disorders. If we had a parvovirus infection, so for instance, if we had aplastic anemia, and you can get congenital versions of these too. Hemolytic anemias, majority of them other than beta thalassemia. And lastly, anemia of chronic disease for normocytic anemias. Macrocytic, we can actually break it down into 2 groups, but don't worry, there's not a huge amount in the megaloblastic. The 2 that we have to worry about mainly are the hematinic, so B12 deficiencies and folate deficiencies. And to just finish off on another acronym for a non-megaloblastic anemia, this is a fantastic one that my GP tutor taught me. And this one's RALPH, so RALPH, so R for a reticulocytosis. So I know we said that usually all the hemolytic anemias are normocytic, but if we get enough reticulocytes being formed, because they are bigger, they can sometimes push up the MCV. A for alcohol, L for liver disease, P for pregnancy, and H for hypothyroidism. So thank you very much for sitting through this video. I hope it's been helpful to actually draw out how a red cell is made and the issues that may occur on its journey before it's broken down by the spleen after 120 days. If you have any questions or comments, leave it down below and I'll try to get back to them as soon as possible. Thank you again.